without further ado, I'd like to introduce Dr. Veronique van der Horst, who
I will take over, yes. So thank you, Althea, for the wonderful introduction, and thank you everyone for coming to a venue where actually balance is being challenged just to get to your seat. So please be very careful when you move about here, because it makes me a little bit nervous. So that's exactly what we're going to talk about today, about walking and balance difficulties and how to get around these. Well, I can just start that we're not good at talking about walking. Oftentimes that's a problem in the office. It's hard for patients to explain what it is that they're struggling with. And it's also very difficult for the doctors to explain what it is that's standing in the way. And why is that? Well, walking is very, very complex. It takes us years to learn. If you look at little children, they are not born and they cannot, they're born, but they cannot walk immediately. It takes quite a bit of time to learn that. And the problem is, once we learn how to do it, it's very hard for us to explain how we're doing it, and it's because it's partly automatic, which makes it very difficult to phrase for us what the problem is. So how do we normally deal with walking? So typically we look at the pattern and you immediately see that there's something wrong with this gentleman's walking. This is from Monty Python Ministry of Silly Walks. So everyone sees that immediately. And this vision, this visual concept is also what we use in the clinic to recognize patterns that are unusual. And sometimes we see a Parkinson pattern, sometimes we see another pattern. There are hardcore ways of measuring movements, and there are several different types. Mobile devices, you can put little dots and follow the dots with a camera. You can leave footprints. So there are a lot of ways where we can measure what happens in walking. The biggest challenge, however, is still how to translate that information to how the brain is working. So we're still dealing a little bit with a black box. We need to do a lot of detective work to figure out how it's working. And we know it's not working like that. There are no screws in your brain that mediate the walking. So I wanted to start with this as a background, because I'll lead you through this talk this morning. And the way we're going to build this up, we're going to first really look at what are the difficulties with walking, with posture, and with balance. And I split them up because they're not the same. Then I go a little bit into detail about where these could come from. There's no clear answer yet, but I'll show you some of the approaches we have been developing here to really get to the core of this problem. And then finally, and that's very important, what can you do to get around if certain problems arise? And there can be different problems that require different approaches. And then at the very end, what is there that we can do also as researchers to close that gap between the problems that patients are dealing with and the development of much better and stronger therapies and strategies. So that's what we're going to talk about. So let's talk with what's wrong with the walking. So walking, even though it's here under one phrase, walking can change in many different ways. So the start can be slow, and sometimes when people get up, they're able to move quite freely. Sometimes the steps get shorter, and the walking looks like more of a shuffling. So that can happen as well. And then the steps get short. Sometimes, even though in Parkinson's disease everyone thinks everything is slow, but sometimes actually the movements speed up. They become really, really fast, but really, really small. And that's called fascination, when the steps are really, really quick. And you would think that shouldn't happen in Parkinson's, but this is also one of the things that patients can struggle with. That the arm swing is behind or not as brisk as on one side on the other side. That's something that we can easily see. Fortunately, it doesn't interfere as much with the overall mobility of the walking and the safety related to it. And then there is a really unusual phenomenon, freezing of gait, which means that the feet of patients get glued to the floor. It can happen when they start walking. It can happen when they're trying to make a turn. It can happen when there is an obstacle. And it can just happen out of the blue. And it doesn't happen all the time, but it happens sometimes. So that's yet another feature of a problem with walking that fortunately not everyone has, but some people with Parkinson's do have that. So already if we're talking about walking, we're talking about a lot of different flavors. Now, what about posture? So oftentimes posture gets somewhat stooped. So it's as if the head and the shoulders are leading the way. And the hips are a little bit flexed, and oftentimes the knees are a little bit flexed as well. And it's because there could be an imbalance between the flexor muscles and the extensor muscles. And what about balance? Balance, again, is different. So some people have problems with balance and don't have much problems with the walking. Some people have struggles with the small steps, but their balance can actually be quite good. So it's not that if one of these features is off that all the others are automatically also off. It can happen independently. And the problems with balance come from the fact that sometimes, especially later in the disease, the postural reflexes become weaker. And to be honest, the postural reflexes also become weaker when we are getting older. People in their mid-70s are all starting to struggle with balance. So it's not something that is unique only for Parkinson's disease. And the way we test that in the office, you may have experienced that. The doctor pulls you backwards and tests the postural reflexes. It makes it difficult sometimes to get up from chairs. And what may happen is that you try to get up and you're being pulled backwards as if there is a force behind you that pulls you back into the chair. So this all has to do with changes in the center of gravity that either is too far in front of you or too far in the back. And then you have to correct for that. If you cannot correct for that, you get into trouble. Okay? So all of these problems can lead to stumbles and falls, and that's not good. And that happens to everyone. This is the King of Spain who's stumbling. People can develop fear of falling, which in itself can stand in the way of moving about. But it's very healthy. If you're standing on a platform like that and you don't have fear of falling, probably it's not good for your survival because you should be nervous about that. Okay, so if you have a fear of falling, it means you need to listen to that. It doesn't mean you need to sit down, but you have to acknowledge that and work with that. It gets more challenging to get from A to B. It takes more time. And it also takes much more energy. And what can be the downward spiral here is that people are going to be less active. They're going to sit down and they're like, oh, let's not do it. And that's what we don't want. Okay? And we get later in the talk, we're going to talk about strategies, how to go about this. And just sitting down is absolutely not the thing to do. It's not going to help you work on these problems. Okay, so are there any questions about this part? So we looked at walking, balance, and posture, and what is abnormal.
Sometimes people's balance might cause because the spine is out of alignment, and there are certain chiropractors who work with just body alignment. Would that be helpful?
So the question is if the balance problem is due to a misalignment of the spine, whether chiropractors can help to solve that. Well, if you would just look at the spine itself, the chiropractor may be able to fix part of that problem. What we're talking about here is how the nervous systems give the signals to compensate for a center of gravity that's slightly off, or for a quick movement that you're making. And of course, by optimizing other factors that also contribute, because we're not only brains on legs, we have a whole body, so optimizing other factors will also be important. Okay, so, and that's typically, and at the end when we talk about what we can do, there is a slide where a lot of those features come in. It has nothing to do with how the brain really works, but optimizing those features altogether really helps with safety and mobility.
Hi, Mark. Let's see, Doctor. I'm fascinated by when we brought up the 5 foot table. And it was a strange thing because it hadn't happened before. I was driving a fish. I started walking and I was heading for the stairs. I realized I was gaining speed.
Mm-hmm.
So when we gained speed, I turned right to stay on the high ground. But I still slipped away. At the very end, I thought I could stop myself by grabbing a boxwood bush,
Mm-hmm.
and all I did was lay me out flat before I landed on the gravel. And it was a very strange thing, and I find it happening more and more.
Mm-hmm. So here is a comment about someone who walks on a slight slope, and at that moment it's as if the speed is being geared up, and it's very hard then to control the speed and say, oh, I'm going too fast, I have to go slower again. And it's a very common complaint, especially when and this has to do with the fascination, the very quick steps that go faster and faster. And oftentimes an early trigger is exactly a slope that's downward, because when we normally walk up, our center of gravity is right here in the middle of our belly button. And then when we are on a slope, if we don't correct for that, our center of gravity will be in front of us. And the only way not to fall is to keep trying to catch that center of gravity. So you're going faster and faster. And because the postural reflexes are not able to get that, pull that center back in, that's actually what then causes trouble. And oftentimes, yes, indeed, there is, if you don't find something to kind of hold on to, it's very, very hard to stop.
Well,
So
I couldn't stop myself, and the push wasn't enough to stop me.
yeah.
And I experienced another one thing. I was walking to the garage, and there was 6 steps now. We moved from one level to time, so now, we're all on one level.
And that's good. One level is good. Okay. So let's move on, because we have a lot of territory to cover. We're now gonna move on to the question, where do these problems come from? From the introduction, you already understand that I will not be able to give you the answer here, because we simply don't know. But we are trying to develop really powerful strategies to get to the core of this. And I'll take you on a little trip. Don't get overwhelmed by the details. This is not about the details. This is just to show how our approach is and how we are trying really to get to the core of this, okay? So oftentimes when you talk about Parkinson's, you hear the word dopamine, and dopamine actually is lost from the cells, the nerve cells in the substantia nigra. And the substantia nigra you can see right there, and it's nice. And black nigra means black. In Parkinson's disease, that area becomes pale. And a lot of the problems that people with Parkinson's are dealing with are due to the loss of dopamine. But is that really the full part of the story? So let's explore that a little bit. Now, if you get dopamine or levodopa from the doctors, what is it that improves most? So it's especially the stiffness and the slowness that responds really well to this medication. Okay. What about walking? Well, you see, nowhere did I put 2 pluses there. So the walking gets better for as long as the walking problems are related to the slowness and the stiffness. But if there is, for example, freezing of gait, in some patients it improves, but in a lot of patients it just gets a mind of its own, and the dopamine doesn't really kick that out. And that's the same thing for the fascination, the very quick small steps where people try to catch their center of gravity. The dopamine is not really able to fix that under all circumstances. So it means that in addition to the problem with the dopamine, there may be other circuitries and other neurotransmitters that are also affected. If we look at posture, it's even harder. Yes, you can correct for it by thinking about it, but the medications are not really great. And for balance, we know that it's really not helping a lot at all. Okay, so probably there are other circuitries that are mediating these problems, and they get weak independently. They can get weak independently and at different stages of the disease. And that's still a little bit of a puzzle. But let's take a look at what we're able to find. So this is an overview of the human brain where the alpha-synuclein, that's the abnormal protein, or it's the normal protein that forms abnormal clusters and clumps in the brains of patients with Parkinson's disease. It's depicted here where that's located most. And if you look at this, you'll see that in the brainstem, and this is that thingy, a little stem here that sticks out, that has the darkest color. And it means that there is a lot of pathology there. But that's a part that we typically don't focus on. We always focus on these parts of the brain and the deeper parts of the brain here, because this is where we do our higher level thinking. But I already explained that for the walking, there is some higher level activity that's very important, but there are also a lot of automatic functions, and they come partially, most likely, from deeper parts of that brainstem. If we make a cut here at this level, and then you look what's in the brainstem, you see that there are those clusters of alpha-synuclein, those little dots, they're there. And even if we go further down, all the way down our spinal cord, and we never think about that part, there is also alpha-synuclein aggregates are sitting in the spinal cord as well. And we know that if there is spinal injury, for example, it's extremely difficult for people to walk. If you have a spinal cord lesion, no one is surprised that you can't walk. So you can imagine if there is a relatively small problem, it may already have relatively large implications for mobility. And it's areas of the brain that we typically don't really think about too much. And that may be where a lot of the problems are sitting. So what do we know about that region? And in humans, we can look at it, but we cannot manipulate the region. We can take pictures of it with MRI scans and other imaging studies, but this area is so small that the details are very hard to pick up. And if for that reason, sometimes we switch to animal models. For example, in mice. And in mice, we can get to these circuitries, and we can figure out that there are different groups of nerve cells sitting in that brainstem area. And the brainstem is here at these levels. It's all brainstem. And then if we, for example, look at the connections to the spinal cord, the area of the spinal cord that's important for the movements of the legs, so all the way down, you see that each of these clusters has very different patterns in the spinal cord. And it means they have different functions in the spinal cord. This area, for example, most likely is involved in tone. This one in how fast the movements, the alternating movements are made. And this system for skilled movements, okay? So all these different systems are just not there to make beautiful pictures. They're there because they're serving a different function. So how do we learn about the function? Again, in mice, we can very selectively target small parts of the brainstem. And we can do that, we can control where we do that, and then we can measure the behavior. And for example, we can look at footprints of mice. And what you see the black color, that's the hind paws. They're large, they're big, and then the red dots are the front paws. And when this mouse starts, before we made a lesion, the pattern looks quite nice. Okay, that looks nice, long steps. But you see what's happening here, the steps get small and short. And here the mouse didn't even move. We had to cue the mice to make it move. And here the paint is already dry by the time it's at the end of the piece of paper. Okay, so this is very similar to some of the walking problems that patients with Parkinson's can have. And of course, we measure this very rigorously. We don't only do paint, but we measure all the length and also the timing of the walking is very important. We are able to measure that, put that in complex graphs, and we can see how a mouse with a lesion compares to the mouse without a lesion and compare different groups. So that's how we go about this. Okay, and then we can also look at tone. And we do that by implanting tiny little electromyography electrodes in the muscles of these mice. And for the mouse that had a difficulty with that walking, where the steps became very short, it turns out that the tone in the muscles, when it should be low, is actually higher at rest. It's too high when it's walking. And interestingly, when this mouse is sleeping, the tone goes down in the first phases of sleep. But when the mouse gets the rapid eye movement sleep, the REM sleep, it starts acting out its, I don't know whether it was dreaming, but the EMG becomes very, very active here, as if it's awake. And that's interesting as well, because a lot of patients with Parkinson's disease do act out their dreams at night. Okay? So there are a lot of similarities here, and we may be onto a trace or a path that we want to follow. So we have been learning a lot about these mouse models over the past few years. And you can say, okay, that's great, but now what are we going to do with that? So we've been able to formulate ideas about how initiation of walking, how speed of walking, and how posture is controlled in the mouse brain. And now, how do we translate that to people? So one way of doing that is measuring initiation of walking, speed of walking, and posture in people who are somewhat older, and do that when they're walking about. And that's exactly what we're doing in collaboration with a large center at Rush University. They follow a large cohort of elderly people. Some have Parkinson's disease, some are healthy, some have Alzheimer's disease. These subjects undergo testing of walking, and they all signed up to donate their brains, their brain stems, and their spinal cords. And we're going to look here at what we can find in the brainstem and in the spinal cord of these people, some with difficulties in walking, some not with difficulties in walking, and we're going to see where the problems are in those brainstems. And we're going to learn an awful lot. We may be wrong with all our hypotheses, but it's a very rich set of data that we're going to get. So we're very excited to get going with that, and we can feed that information back into our mouse models, and also we'll be able to move other studies forwards in humans, because that's what it's about. Okay, so that was the second part of the talk. Any questions about that part?
Would you please explain what you meant that they act out the dream?
So what happens when we... Okay, so the question is what happens when patients act out their dreams? So when we sleep, there are different stages of sleep. First, we go into deep sleep, and we don't dream too much there, and our muscles are very relaxed. Then we go into a phase of sleep that's called rapid eye movement sleep. It's a phase of sleep where our brain, our cortex, is very active. So if we look at the electroencephalogram, the EEG, the brain waves are different from when they are awake, but they're very close. They're much more active than during the deep sleep. And that's when we think we're having our dreams. So normally, in order to avoid us acting out our dreams when we are in that phase of sleep, the tone of the muscles is really turned off. Okay, that happens somewhere in the brainstem. It's not one spot. It's several spots in the brainstem that are involved in the shut off of the tone. Okay, so we're paralyzed. We're paralyzed when we are in REM sleep, except for our breathing muscles and our sphincter muscles. Now, what happens in Parkinson's is that the centers that shut off the tone, they're not so good anymore, and they get a little bit rusty. Okay, so then when you make the transition into REM sleep, there is still some tone, or the possibility to regenerate tone is still there. Now, when you have a dream that you're watching butterflies, nothing bad will happen because you're just in bed and you're pretending you're watching butterflies, and nothing is going on, and nothing is going on that can hurt you or the bed partner. Now, but when you imagine that you are dreaming that you are picking up a stone and throwing that to a bear, okay, or you're dreaming that you're chopping wood and you're dreaming that, you may actually be the patient may be very active in bed and exactly execute those movements. And of course, we always are worried about that because it can injure the patient itself, but it can also injure the bed partner. So, and that can happen. It's very weird. It's very unusual, but it's one of the typical features of Parkinson's disease.
What if you're a Parkinson's patient and you notice that you stop dreaming?
So the question is, what if you notice that you stop dreaming? So to be honest, I'm not sure what that would mean, but it's not something to be worried about. Okay?
Could be actually a good thing, right?
Exactly. Yes, exactly. Okay. Yes. Another question.
More of a statement. I was having very early very violent dreams. I lost myself out of bed and ended up on a nightstand around 4 months in bed, 4 paddles getting too quickly. But anyway, language was terrible. And I just want to cover these things tradition versus.
Mm-hmm. Exactly. So this is a comment about how these acting out of dreams episodes can be really, really almost violent and really hurt patients and bed partners. So if you notice this, you can bring that up to your doctor, because we all know that this can happen, and there are ways to treat that independently of say, balance problems or posture problems. So there are treatments for this. So if you notice this, bring it up, okay? Good. So now, in a very important part of the talk, how do we go about these problems, okay? And the way to go over this, I will indicate what you can do, okay? And when it would be wise to do that. It's not like one intervention fits all of the problems. Because we know they're actually different entities, and it depends a little bit on the phase of the Parkinson's. And at the very end, I'll also go back to the research and indicate where we hope that we can guide our research to come up with much more powerful interventions as well. Okay? So, good. Now, what can you do? How to get around these problems. So let's see. Let's first explore a little bit what is out there and what we can and what we can do. Walking. Exercise is big. Medications can help because it improves the stiffness and the slowness, and that certainly contributes to the walking problems. DBS can help a little bit, but it's not going to fix everything. And then a cane and a walker can be very helpful as well, just to stay safe on your feet, because that's a very important goal as well. Now let's see what that is for posture. Exercise is a little bit smaller, cannot do that much. Medications, not so good. DBS has worked in some patients, has not worked in other patients. So it's not a mainstream to go after posture. Cane and a walker won't really correct that, but will help you stay on your feet in a safe way. Balance. Exercise is big, very big, and we'll get to that. Medications are tiny, so there are no medications that can improve balance. But this is something very important to keep in mind. There are a lot of medications that can worsen balance. So sometimes it's good to go with your doctor over your medication list and see which medications can actually make things a little worse, okay? DBS is very tiny. It's not going to help a lot. And the cane and the walker are your friends if it comes to balance. Okay, so let's go into a little bit more specifics about the walking. If the walking is weak, you have to practice walking. Okay, the walking may not feel as automatic, but by training this over and over again, the circuitries in the brain that are not affected by Parkinson's, and there are many circuitries in the brain that are not affected by Parkinson's, can compensate a little bit, at least for as long as you pay attention. So this is very, very important to do. Strength, endurance, and flexibility are all going to help because you will have more reserve. But if you only would do strength training, like, okay, I'm going to train my biceps and now I'm going to hope that my walking gets better, that's not the right approach. So you will have to get the walking in to make the walking better. And now, interestingly, for some of the problems that are quite specific for Parkinson's, there are special strategies. And these can be very powerful, also given that we oftentimes cannot fix these problems with the medications. One of them is cueing. So when you cue, you give a sensory stimulus. It can be visual, it can be auditory. Interestingly, a tactile, a touch stimulus oftentimes doesn't work as well. It can have the opposite effect. And this is being used in gait training, sometimes by physical therapists. They put on a beat or a metronome. You can use this yourself. If you do your walking in the winter in the mall, you can put on a little bit of music and you'll notice that some music really gets you going. This works for some people, doesn't work for everyone. And what your good beat is also very individual. And you would think that if you want to improve your walking and you want to make that stronger, you need to increase the frequency at which that happens. Wrong. You actually have to go slightly lower to what your default is, and apparently that gives your whole system more time to do that. So don't want to go too fast. You have to pace that system and then you'll do much better. Okay, so that's very interesting because you would think, oh, you need to go move, 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 but that's actually what you should not do. One question here?
So my instinct on a treadmill to speed up is not very small.
Well, you can push yourself a little bit. Well, when you speed up, you should not speed up the frequency at which you make the steps. So keep the steps nice and big and long, but relatively slow rather than this. Okay? And in addition to those auditory cues, some people do well with visual cues, and there are research groups that actually try to make use of those visual cues. And what works for one person may not work for the other, so it's always good to have more strategies around. Now, what about freezing of gait? That's that problem where the feet get glued to the floor. The problem there is that it doesn't happen all the time. It sometimes happens, it's unpredictable, and it can really get you stuck in a position. And what can you do there? So cueing can be used as a first aid there as well. And this again is something you can explore if you have troubles with freezing of gait. You can start counting aloud, or you can start counting in your head. Some people think of marching music, or they start singing or humming just to get in the rhythm, and then they go, okay? There are other cues. You can make use of cues, visual cues. You can use your sights. So some people imagine that in front of the feet that are glued on the floor that they see something, like imagine that there is a fly or a bug and you want to step on it. Because if you do that, It's actually a different part, a different circuitry in your brain that you engage in doing that. It's no longer something automatic, but it's some goal-directed behavior or goal-directed step that you're doing, and that's crushing the insect. And there are laser canes that make use of that. They give a visual cue, but you can also get a tiny little laser pointer, hold that in your hand, and point the dot to a position in front of you, try to step on it, okay? So that's also something that can be tried. Now, what about if you always get stuck in that same corner of the house? It's a trouble spot. It just happens over and over and over again. What you can do if that happens, and you can play with that, is put some visual stripes, put some tape on the floor, and that can also be a visual cue for you to step over those stripes that you put there. So these are all things that can be explored, and it doesn't prevent you from the freezing episode, but it can get you out of the freezing episode much faster. Another strategy, that's thinking big. Okay, now how does that work? How does it help to think big? So what happens in Parkinson's is that the sensory feedback, and not only for the movements of the arms and the legs, but that's also true for the sound, there is something off with the sensory feedback. So if patients are talking, they think they're talking loud, but they're not talking that loud at all. And that's the same for the movements. If you make the movements, they can be very small, and only when you look at it, it's like, ooh, I have to make that bigger. Okay, so there is something wrong with the sensory feedback. And if you are aware of that, you can actually train yourself to really exaggerate the movement so that you think it's normal, but actually by exaggerating, you can increase the size and the amplitude of the movement. And that's being used as part of speech therapy. Lee Silverman speech therapy makes use of that. And it can also be incorporated in your normal exercise routine. So when you're on the treadmill, focus on making the steps nice and big. Okay, bigger than what your normal default is. It requires a lot of extra attention. Okay, so if you're tired, it's not going to go well. And you cannot keep up with that oftentimes all day, all the time, and compensate and think about that, because it really requires quite a bit of energy. But again, by training this, and sometimes by overtraining it, you put yourself at a slightly better level. Now, what about posture? Can we practice posture? Sure, we can practice posture. I'm thinking about it now. I'm standing straight, but in 2 minutes I'm starting to slump over again because that's the default. And that's even more something automatic than the walking part is. So it's very hard to train that, but it is important to focus on strength and flexibility exercises, because if you look at the picture, what you see is that there is some flexion at the hips, there is some flexion at the knees, and that means that the flexor muscles are doing more work than the extensor muscles. So by keeping all the muscles nice and supple and flexible, you're not able to tell the brain, don't make this my default, but you actually make sure that the muscles that shorten up a little bit don't shorten up more than they should do. So it helps keep the problem in control, and it's important to pay attention to that. You can do that as part of more complex exercises. You can also work with a physical therapist to really see, okay, which muscle group should I stretch and which should I not stretch? Okay, so let's move to balance. Practice, 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 practice. Strength flexibility helps a little bit, but here it's really the complex movements that help. And there's been a lot of research going on lately that it's all good as long as these complex movements are integrated in the exercise regimen. The thing is, the balance really gets challenged when we do something. When I reach out, my center of gravity moves in that direction, and then I have to compensate for that. So it's these complex movements that you make that challenge your balance control. And that's exactly, if you want to improve your balance, that's exactly what the challenge should be. Slight shifts in the center of gravity so that you can learn how to compensate for that. And there are tons of exercises you can do for that. We know that Tai Chi is very, very powerful for that. Dance therapy is very powerful for that. Boxing is probably good for that. Always think about physical therapy as the gold standard. It's always good for you as long as you do exercises as part of physical therapy and not, the massage is good, but you want it to be something active, okay? So as long as you do multimodal exercises as part of physical therapy, it's great. So for balance, remember, a lot of types of exercise are great as long as the movements are complex. And whether you do that standing on one leg or whether you hold on to something, if you need to hold on to something, you hold on to something, okay? So it doesn't have to be a yoga pose on one leg upside down. It has to be titrated to what you can do. We have a question.
Yeah, I was just wondering, I took the boxing this summer and really did a lot of it, and I liked it, but then I realized it was doing a lot of work on my core, and that made a huge difference in my posture and my balance and everything else, and I'm wondering if there's any emphasis on core work for Parkinson's.
Yes, so when you do these complex movements, okay, we think that we're moving our arms or removing our arms. What you actually are training is you're training your core to compensate for your arms and your legs sticking out in different directions. So you think you focus on your arms, but what's actually happening is you do train your core to keep that center of gravity around your belly button. So the core is absolutely, you're right, it's absolutely important. And that's why it's so important when you do core work or strength work, not to isolate one muscle, okay? So don't go in machine and isolate this muscle and do this. So if you would pick up 3 weights, you think you're training your biceps here, but at the same time, because you're standing, you also train your core muscles to stay where you are, okay? So, and that's the way we move about. We are not a bundle of arms or a core, we are a whole entity. And in order to function best with what we're doing and how we move about, if you keep it broad, that's exactly what you should do, because that's how we move, okay? So the legs are important for the walking, but there's a lot of other body parts that also need to follow with the walking itself, and the posture and the balance, okay? Okay, so some examples here. Now, what about walking and talking? It's quite interesting to see that these pictures pop up, because there is a texting lane and there is a no texting lane. So, question is, what happens when you're texting? What happens when you're texting? You're distracted, and what happens then? Why would they give you a different lane? You're not straight, that's true, and what else happens? You slow down. You slow down a lot. You can see that on the street, actually. There are people that all of a sudden start slowing down, and it's because they're like doing all of that, okay? So that's true for walking and texting. It's also true for other things that you do when you're walking, especially when you need more energy to focus on the walking. So it's also true for walking and talking, or walking and carrying something, or walking and think about the biggest problem in the world. Okay, that's all gonna slow down your walking. And that's something that's very important to keep in mind, not only for the patients here, but also for the caregivers, the spouses, the family members, because if you're gonna start a difficult conversation when someone is trying to negotiate a difficult cobblestone path, it's not gonna go well, okay? So I tell all my patients they have the right to refuse to engage in the conversation until they're done with their walking, okay? Because that's important and you have to stay safe.
You write that down.
Yes, I can write that down. Okay. Yes.
Sort of anecdotally, I've noticed that can happen, the distractions when they're just carrying something
Yes.
and trying to balance it.
Yes.
I started refusing to let them carry the dishes to the sink.
Yes. Exactly. So anything you do in addition to, so the normal walking is already very complex because you have to maintain your balance, you have to control your speed, you have to negotiate the hurdles that are always around us, walls, rugs, and then if you're also challenging that system further by carrying things, you're changing your center of gravity and it's even harder to compensate. So anything you do in addition to the walking can be a distraction. And this actually has to do what we think this has to do also with cognitive reserve. So to integrate all these things that I just mentioned, speed, direction, difficult conversations, you really pitch into your cognitive reserve to do all these things at the same time. Doesn't mean you can do them one by one, but if you do them all at the same time, that's quite taxing for the system. That can be trained, and it's actually important what we do earlier in life. That's what gives us extra cognitive reserve. Some of it is genes, we cannot change that. That's how we were born. But for example, people who learned a second language, they have more cognitive reserve. Social interactions are really good for your brain. So when we start talking about assistive devices that help you get out of the house, it's because you don't want to give up these social interactions. That's as honey for your brain. That's what it likes. Your brain likes social interactions, and it's complex. So it's really good training. And then, of course, exercise may also help with boosting the cognitive reserve. And there are several studies that are going on.
I'm curious, under exercise, yoga is never mentioned. Is there a particular reason for that?
So the question is, why don't I mention yoga? So yoga can be in this list, absolutely, okay? This is not a comprehensive list. There are probably more forms of exercise that are good than I can list. The problem is that there are, if we look at how many studies there are that really prove this, there are not that many studies that prove all of this. And that's a little bit of a gap. But all of those exercises are good, okay? And some may be better for certain parts. Like yoga is really good for also flexibility is in there, balance is in there. Walking, it may improve a little bit, but is probably not boosting that directly. So the list is much, much longer. If I put, once I made the comment, if I put belly dancing in there, belly dancing is probably really good for your balance, okay? Because you change your center of gravity all the time and try to chase that. But the point is make it complex for balance and make it complex if it's about cognitive reserve. Again, pumping that one muscle in the machine, it's not going to be that much of a challenge. So it has to be something more comprehensive. Yoga is wonderful, okay? Multitasking. Don't multitask while you're walking. That's the take-home message here. And yeah, so keep that in mind. Other things to think about. So these are things that are not only important for people who struggle with Parkinson's, but some of them are common sense, but sometimes they're forgotten a little bit. So shoes, okay? If you wear elegant shoes and you really stand on your toes, it's much harder to keep your balance. So make sure that you pay attention to shoes. Shoes should be fitting nicely. You should be comfortable in them. And the platform should be big enough. The bigger the platform is, the more support you have. Okay? Light. So especially when the balance is off, and sometimes the balance is also off because there is a neuropathy. So the nerves in the toes don't give the signal back to the brain. That can happen independent of the Parkinson's. It's a very common problem. If that's the case, by keeping your eyes open and you can compensate a little bit for those troubles with the sensory feedback. You can keep your eyes open, but if you do that in the dark, you're not going to get a lot of information in your brain about where your toes are. So you need light to do that. So when you make a bedroom break at night, make sure you have some lights on. Talking about sleep and quality of sleep, try to make the lights a little bit in the yellowish hue and not in the blue hue or bright lights, because blue lights and really white lights can keep you awake. Okay, so yellow lights are good. Rugs and carpets can be your enemies, and I know sometimes it's hard because there was a rug that you had for many, many years and you're really attached to it, but it can cause a lot of trouble. So from time to time, really look at what is there, should that still be there in that location, or should it be somewhere else, or just should it go? Open passages. Open passages are very important if we talk about freezing of gait, because if it's cluttered, it oftentimes triggers a freeze, so to say. So think about that as well. And sometimes just removing one object from a difficult corner can help there. Then the most dangerous place in the house is the bathroom. So think about things where you can be safe. The bathroom is slippery. We oftentimes close our eyes when we're doing something in our face, and it's really, really a very dangerous place. So a chair can help, railings can help, and there are a lot of tools that can just increase the safety. And there is nothing that can compensate for that, and it's just something you put on the wall. And it can make a big difference when we talk about safety. Okay, now we talked a lot about exercise and other strategies. So let's go very quickly over the medications, deep brain stimulation, and assistive devices. Okay, and then we're going to explore a little bit about future therapy. So medications, they're not really medications that can fix these problems, unfortunately. Okay, we don't have these in our hands. Sometimes if we use medication that boosts the cognitive performance, like the acetylcholinesterase inhibitors, examples are donepezil or Aricept, it can boost the cognition a little bit. Sometimes it also has a positive effect on the walking, whether that's through the boosting the cognitive reserve part, or whether it's through other circuitries, we don't quite know. Doesn't work for everyone, and it's not going to make the difference between day and night, but sometimes small things can happen. Amantadine has been tried. Sometimes it works a little bit, especially for the freezing of gait. Sometimes it just doesn't do anything. And then there are other medications as well that may modulate the walking a little bit. And there's certainly studies ongoing where groups of researchers look at what the effect really is when we measure it, because a lot of this is oftentimes anecdotal and hasn't really been tested in good trials. What about deep brain stimulation? Because that must be a miracle. If you go get surgery, it should fix everything. Well, we already talked about that part of the problems are due to dopamine deficits. And the deep brain stimulation is really good for that part as well, because that part of the brain is being targeted. But for balance and posture, the results are not so great. And sometimes the walking gets a little worse with deep brain stimulation for certain targets. There have been recent studies where, other than the standard targets, the standard targets is this target here, the subthalamic nucleus, and the globus pallidus. Some of the surgeons have gone down further into the brainstem. okay? And that's where one of those electrodes goes much deeper. Some patients did well, some patients didn't do much better at all. So it's a very scary area to go in with a big electrode, and this is certainly not something that's mainstream. So in this sense, it may be a very important area to target, but is this the most elegant way of getting there? That's one of the questions. And other areas are also being explored with deep brain stimulation. But the problem again is, what's good for one problem is not always good for another problem. So it's always a balancing act, and that's because the Parkinson's disease as such is really a systems problem, and it's not just one node in the brain that's off. Okay. Now, what about assistive devices? So canes and walkers. Whenever we bring that up in the office, oftentimes there is a lot of resistance to that, as if the cane and the walker, really form a hurdle for a lot of patients to use. And it's actually not a hurdle. It's not meant as a hurdle. It's actually meant as something to prevent falling over hurdles. It can be really important for safety. And they're elegant canes, and you can show them around to your bodies. And the walkers also develop over time. I think in the Netherlands there are walks or races for people with walkers. And actually a lot of people take out and bring out their walker and participate in that. And the main thing is really that you are able to get out, to see your friends, to do the things that you love to do in a very safe way. So if the alternative is that you don't go out of the house and you're going to sit, maybe do some of your exercises there, but that's really not good. So if you can go out and about with a cane or with a walker in a very safe way, that's really worth thinking about once you're ready for that, okay? Now, what's being done in research? How can we push these problems? We'll be talking about assistive devices and exercise. Isn't there something more powerful that we can do and really target to one of these problems? So, as I explained earlier, we're trying to translate the ideas that we've been developing in the mice. We're trying to translate them back and test them for human walking using the post-mortem tissue and the walking information we get when people are still walking about. So we're going to learn a lot from that. But is there more that we can do, and are there things that stand in the way here? Because a question we oftentimes get is, well, yeah, that's great. You're comparing mice walking with human walking. But those mice are very tiny. They walk on 4 legs, and we don't really walk on 4 legs. So is that really valid what you're doing there? And that's an important question, because if we can fix mouse gait, but we cannot fix human gait, we have not really achieved a lot. A much more powerful question is actually not to focus on the differences, but to really look at these two different models and see what are the similarities, because if there are similarities, we have something we can work with. Now, are there any similarities? Now, is this a mouse or is this a human? Human. And that's the mouse, because it has the front paws. But you see that the same type of patterns are very similar. They're in a different dimension, but they're in a very different pattern. And that's when we look at the spatial measures. This is just on a gait mat where people walk on a big mat, or in the mouse, they walk on a sheet. Interestingly, not only the spatial, so the length of the steps behaves in a comparable way, also the timing of the walking is behaving in a very similar way. These two sets of data look very similar. This is human, this is mouse. Okay? Here we ask humans to dual task. They are asked to do difficult calculations backwards. And the pink dots here, they go up. And we also have a mouse model where we can make this abnormality pop up. Okay? So that's extremely interesting. And this gives us really a tool to further translate what we find in humans to mice and what we find in mice back to humans. So it gives us the opportunity to go much faster and develop our ideas and test them. Now, what happens with these curves here in people with Parkinson's? So interestingly, if we look at this curve, this looks very, very different. And it's so markedly different that we may be able to use this as a marker, actually. This is a data set we got from a group. We haven't followed patients yet from early in the disease till late in the disease. We don't know how these curves change when the patients are on medications or off medications, when they have freezing or gait or not freezing of gait. And given how powerful this data is, that's actually what we're starting to do here, right here in this center. Dr. Ludici will be the leading investigator on that study, and this study is expected to start in the fall here. And this will be very, very important for us because it will allow us to really integrate the different models that we were working with and accelerate that. And altogether, this is important to understand then how later on how the wiring in the brain works in humans and not only in mice. But in the end, the question is, and that's the big question, is great if we understand where the problems are coming from. But now, can we fix these circuitries? Because it's nice to know, but what are you going to do about it? And that's also a line of research where we have been making a lot of progress over the past years. And that has to do with viral vector therapy. And I'll take you through this. This project is not specifically linked to walking and balance, but it's just a proof of principle type of project to see whether this new approach that I'll explain, whether that also works in a disease model to improve a problem, okay? Because we're really good at making problems in mice, but we need to improve the problems. And the viral vectors, and I'll get to what that in holds, but we have been using that in our really basic research for quite a bit of time, and we've been learning so much about the circuitries, how they work and how they're built. And why not use a tool this powerful also to try to fix circuitries that are out of balance in Parkinson's disease, okay? So Parkinson's disease, you have again loss of dopamine, circuitries get out of balance. And what happens then, problems with movements arise. So the movements are slow, they're stiff, and they're shaky. And that's really as if the brake has been applied to all of the movements, okay? So what if there is a problem if the brake is too strong? If that happens to your car, you bring it to the mechanic. And the mechanic is going to loosen up the brakes and the problem is fixed. So why can't we do that with the brain? Well, we need to know where the brake is. And an important node that acts as a brake in Parkinson's disease is exactly that subthalamic nucleus. Can we dampen the activity of the subthalamic nucleus? Oh yes, that's being done with deep brain stimulation, for example. And, but that requires hardware, so you have to have a battery in and a lead in the brain. And sometimes the problem is that the stimulation has to go around fiber tracts, and that can sometimes cause some limitation on how we can use it. So what about those viral vectors that we've been using in the basic innovative research approaches? Can we use those? Sounds scary. Okay, because you talk about the virus. So a virus has a message in it. And if the virus likes to go to nerve cells and neurons, nerve cells, it sticks to the nerve cells and it delivers a message to the nerve cell that says, make more virus. And that's what happens. So that doesn't sound good. Now, what we do with the viral vectors, we remove the bad message and we replace it with a good message. And for example, a message to integrate some extra channels that don't occur anywhere else in the brain. And if we then deliver that message through the viral vector to the nerve cells that are being targeted will incorporate that channel. And then the interesting trick is that the channels as such are not going to do anything yet. So they're not making the cell go faster or slower only when we give a drug that only targets those channels. Can we turn those cells on or off? And we can do that by giving a lot of drug, we get a big effect, or we can give a little bit of a drug and we get a slow effect. And if we don't want to have the effect, we just don't give the drug. So how would that work? So the viral vectors can be delivered in the subthalamic region, and that's what we've been doing in this project. But once we know those circuitries that are involved in balance, posture, and problems of walking, if we know those circuitries better, this approach can be delivered pretty much anywhere in the nervous system, okay? Because we don't have to put a big electrode in a spot. We have to deliver a small amount of the viral vector once, okay? Then you give the drug, and the drug changes the circuitry, and we can turn that on and off. So it's reversible as well, which is also important because we want it to be safe. Okay, so that's what we're doing from our part. And of course, you know what you need to do from your part, and that's get up and be good with exercise, cueing, thinking big, training, social activities, all of that stuff. But stay within your limits, okay? So it's sometimes so overwhelming what we see and read in the newspapers and in the media. And that's actually what we're going to talk about in a couple of weeks in a special symposium here. It's really important that you stay with yourself, okay? What's good for someone else is not necessarily the best for you. And if you feel uncomfortable doing certain types of exercise, it's probably because you're reaching out too far and may need a little bit of help getting to that point. And what you can do depends on the stage of the Parkinson's. So what's good now may not be the best thing to do 5 years from now. It depends on how much you're comfortable with doing exercise, how athletic you are to start with. So some people are just klutzes, and they will always be klutzes, okay? And also other medical conditions. There may be other medical conditions that stand a little bit in the way. Start out slowly. This is not a race. This is something, it's a long-term investment that you're gonna make. So start slowly, keep going. Don't overdo it because you're gonna hurt yourself or you may get injured. And that's exactly what you don't want. And if you're a little bit uncomfortable or you don't know what would be best for you, talk to your doctor, okay? And we're the first ones to say, okay, we have these classes, that's great for you, or if the problems are getting a little bit more complex, it's a very low threshold to send you to the physical therapist for a one-on-one evaluation. And they can also help you with the program, not only physical therapy, but they can also indicate which of the other programs are important for you to do. And just to show that there is not one thing that fits everyone, here a little bit of a flow chart from an article by a Dutch group. When you're early on in the disease, you can do participate in group exercises, do all of that. It gives you a really good basis, and when the disease progresses, if there are problems with the freezing or with the multitasking, it can become a little bit more complex, and you may need to make use of the cueing strategies we talked about and training more of the complex movements. So this can shift over time. So again, listen to the feedback that your brain and body is giving you about the exercise you're doing. If you're not comfortable, it's probably not the right thing for you to do. Now we talk a lot about this in the office, but we don't only talk about it and think about it. Most of the fellows that train here I think they got the message when they got the training, and the movement disorders training, I mean, and we're all very active, and we put in our time investing in making a good basis now, because we never know what's going to happen, okay? So that's important really for everyone. And we're almost through the talk. Support that we got to get these studies going, very, very important. We got now funded by several grants from the National Institutes of Health, so that's very important to develop these projects further. Especially for the higher risk projects, the support that we got from people around here, maybe people in the audience, all types of foundation, has been absolutely crucial to develop some of these quite risky ideas, and that's been really, really very, very important to get going, and now it will be important to move this all forward. The team of people that's been involved in these projects is growing. A lot of them is from the side here, but we also reach out for very strong and powerful collaborations as well. Okay, and that concludes the end of the talk.